My name is Anne Chiang. I'm an associate professor of medicine at Yale University, and I also serve as the associate cancer center director in clinical initiatives. I lead the small cell program here at Yale and am excited to talk with you today about current treatments and unmet needs in limited stage small cell lung cancer. Patients diagnosed with limited stage small cell lung cancer who are ineligible for surgery are treated with standard of care concurrent chemotherapy and radiation, and subsequent prophylactic cranial radiation is recommended for patients with good response to chemoradiation. Well, according to the NCCN and ESMO guidelines for stage 1 to 3 small cell, in other words, limited stage small cell lung cancer, the recommendation is for concurrent chemoradiation. And specifically, this is 4 cycles of cisplatin and etoposide concurrent with thoracic irradiation. Carboplatin and etoposide is an alternative if the patient cannot manage or has comorbidities so that they can't receive the cisplatin, although you should be prepared to have more myelosuppression with the carboplatin. Astro guidelines suggest twice daily radiation to begin with cycle 1 or 2 of chemotherapy, and also for stage 1 or 2 and 0 and medically inoperable patients to consider SBRT or conventional fractionation is recommended. If your patient can't receive concurrent chemoradiation because of poor performance status or comorbidities or the disease volume, sequential chemoradiation is also an option for them. For stage 2B through 3 patients, NCCN recommends PCI or prophylactic cranial radiation for patients who respond to chemoradiation. So in other words, a complete or partial response to chemoradiation and maintaining a good performance status. That's 0 to 2 ECOG. But there does need to be caution in older patients, especially 60 years and older. And prophylactic cranial irradiation is not recommended for patients with poor performance status or impaired neurocognitive function. It's recommended to have shared decision making for all patients. I think we are, as a field, using less of prophylactic cranial irradiation. According to the ESMO guidelines, PCI should be considered for patients who are 70 years or younger, again, with a good performance status. It can be offered to patients with a PS of 2, performance status 2, although this is, again, a shared decision-making space. If your patient is 70 years older or frail, this may be something that you opt out of. Again, I usually talk to my patients about this in a shared decision-making conversation. Astro, again, recommends it for patients less than 70 years with chemoradiation responsive disease and a good PS, and the preferred dose is 25 gray in 10 daily fractions. We have a lot of established data dating back to the early 1990s that did reveal the benefit of combining chemotherapy and radiation. There was data from 2 meta-analyses that showed adding thoracic radiation to chemotherapy increased the 3-year survival rate by 5% and the intrathoracic tumor control by 25%. Overall, concurrent chemoradiation does lead to superior efficacy outcomes over sequential treatment. And then in terms of the actual fractionation, BID or twice daily radiation treatment is preferred over daily. This dates back to the Thoracic New England Journal trial. That's the Intergroup 0096 trial that showed that 45 gray twice daily was superior to 45 gray daily, and that improved the 5-year survival. But it was more toxic with more cases of grade 3 esophagitis in the twice daily regimen versus daily regimen. And since then, a number of studies have used 60 gray plus concurrent chemo RT in a daily faction that's revealed reasonable outcomes. And I think that is has been probably the most common schedule throughout the community. It certainly is more convenient sometimes for the patient to do that once daily rather than twice daily. There has been final phase 2 survival data published at ASCO 2023 that showed that 60 gray BID was significantly improved overall survival compared to the 45 gray BID with a hazard ratio of 0.69, significant p-value of 0.04 without increasing toxicity. Most recently, the CALGB 30610 RTOG 0538 trial showed that 45 gray BID showed similar outcomes to 70 gray daily, and the CONVERT phase 3 trial showed that 45 gray BID remains the standard of care versus 66 gray QD or daily. Specifically, if we look at outcomes from the CALGB RTOG trial, this showed that the overall survival was similar with 45 gray twice daily versus the 70 gray daily, and the hazard ratio for death was 0.94 with a p-value of 0.594. The median overall survival for the 45 gray twice daily was 28.5 months compared to 30 months for the 70 gray daily, and the 5-year overall survival was 29% versus 32%, and the overall grade 3 or 4 esophagitis and dyspnea were very similar. In the CONVERT trial, which is a phase 3 trial designed to show superiority of 66 gray daily versus 45 gray twice daily regimen, this trial was just presented at the ELCC in 2024 and showed OS similar between two arms with a hazard ratio of death 1.13 and its p-value of 0.247. Specifically, the median overall survival for the 45 gray twice daily group was 30 months, and for the 66 gray daily was 25 months. The 5-year overall survival was 34 versus 32%, and the grade 3 esophagitis was 0 in the twice daily regimen and 3% in the once daily regimen. I think this is an area where we usually, in our center, we definitely discuss with the patient the BID or twice daily regimen and try to make it work out for them. Sometimes they prefer that because they can get through their radiation in a shorter period of time, but other times it's just not possible that for them the feasibility of or logistically try to get to the clinic twice in a day is just too difficult. I think the outcomes that we expect for these patients with concurrent chemoradiotherapy are quite good. The response rates are the initial response rates are up to 90%, especially in patients with the disease confined within that single radiation field. The median overall survival rates are still somewhere around 25 to 30 months. And the 5-year overall survival is about 1/3 of the patients. So even though we are curing some of these patients, and that is the intent, we still have about 2/3 of the patients recurring or not surviving past 5 years. So we definitely need to have better outcomes here. We do have data that shows that starting the thoracic radiation with the first or the second cycle of chemo is better. Often these patients are very sick and they present in the hospital with bulky disease, SVC syndrome, or other symptoms. They're very symptomatic. And so it's fine to get going with the first cycle of chemotherapy. We often do this in the hospital, and then that helps with the symptoms, and then it helps give us time to plan for starting the radiation with the second cycle. The long-term outcomes have improved over time, and that's probably also partially due to improvements in staging, for example, using brain MRI and PET imaging, as well as the differences in RT planning and also in supportive care. The side effects that we usually see for our patients going through chemoradiation include fatigue, cytopenias, esophagitis, pneumonitis, some GI toxicities. The hematologic side effects or myelosuppression with concurrent chemo-RT versus sequential are usually more pronounced. So you have to trade off between, again, the performance status versus the benefit of doing it concurrently. And older patients, of course, are at increased risk for treatment-related toxicities. I think it's important to note that about less than 5% of patients are diagnosed with stage 1 to 2A, so T1 to 2, N0, M0 disease. And I think these patients are incredibly important to identify and to have a multidisciplinary discussion around, because the NCCN and the ESMO guidelines do recommend surgery in a context of a multimodal treatment approach for these patients. If you have a T3 patient based on size who's still node negative, you could consider surgery as well. It's really important to have mediastinal staging, so extensive pathologic mediastinal staging to make sure that you don't have nodal disease. And the aim here is really for complete resection. As per NCCN, lobectomy is preferred with mediastinal lymph node dissection. ESMO, the same thing, systematic nodal dissection. And all of these patients with a complete resection should be treated postoperatively with chemotherapy, adjuvant cisplatin, etoposide. If possible, again, if they can't tolerate the cisplatin, carboetoposide is okay. For especially for R0, N0 to 1. If they're R0 and 1, NCCN recommends considering postoperative mediastinal irradiation. And for R1 to 2 and or N2 discovered at time of surgery, as per both ESMO and NCCN guidelines, the recommendation is for subsequent concurrent or sequential chemoradiation. There's clearly an unmet need for patients to have better treatments. Despite these really great, incredible initial responses often to chemoradiation, the long-term outcomes remain poor. And I think that we need to still optimize our RT dosing regimen. We need prognostic markers to risk stratify and to guide treatment intensification or consolidation afterwards. And I think that, these patients are still at high risk of recurrence, with unfortunately about 90% of relapses occurring within 2 years. And multiple phase 2 and 3 trials will report out in the next few years that assess the use of immune checkpoint inhibitors with or without chemoradiation in limited stage small cell lung cancer. Some key trials are 2 years in duration to study the role of immune therapy in preventing relapse. So these are really important trials, and we look forward to them. Long-term survivors have a very high incidence of CNS impairment, often independent of PCI, and we do need more options for CNS management and control. Finally, patients that are elderly, so greater than or equal to 70 years, are really unrepresented in clinical trials. Patients from diverse populations are also underrepresented in clinical trials. And so we do need more data supporting their optimal treatment. Thank you.